So what we're going to discuss today is the evidence for peripheral nerve stimulation for chronic hemiplegic shoulder pain. So I'm clinically a physiatrist who treats stroke survivors. That's both inpatient and outpatient, but my research is about the use of peripheral nerve stimulation in the treatment of chronic pain. So there's a natural overlap with the hemiplegic shoulder pain, which this treatment was actually initially designed for. So these are my disclosures related to the discussion today. So I have support from the National Institutes of Health to study peripheral nerve stimulation, the treatment of chronic pain. I've also had some relationships with SPR Therapeutics, which is a company that sells devices for peripheral nerve stimulation. So the objectives of this discussion is to go over the current evidence regarding efficacy of peripheral motor nerve stimulation for the treatment of hemiplegic shoulder pain, then identify the implanted and percutaneous approaches to the treatment, as well as introduce to you a theoretical mechanism of action for this treatment for hemiplegic shoulder pain. As I go through this, please interrupt me. I'm happy to answer questions or clarify anything. Somebody will just have to let me know if something comes up into the chat, which I won't be able to monitor. So shoulder pain is common after stroke. For those of you who treat stroke survivors, likely see this all the time. It's estimated that for those who have moderate to severe impairments after stroke, that 60% of individuals will experience shoulder pain. So this is a particular problem when we're focusing on rehabilitation outcomes. When people's shoulder hurts, they have difficulty participating in therapies, and much of what we know about the neuroplasticity to improve recovery with therapies is based on repetitive task practice. And that can be hindered by disuse for people who have pain at their shoulder that makes them not want to participate in the therapies. Outside of recovery, this can still be a problem with function. So there are obvious ways that shoulder pain affects function, such as affecting the way somebody dresses if they're trying to get an arm through a sleeve, but then also in non-obvious ways. 13% also say that having shoulder pain after a stroke can affect their walking. As with any chronic pain syndrome, hemiplegic shoulder pain is associated with worse quality of life. And for these reasons, this is important in the rehabilitation of people after stroke. If we look at a list of what has been proposed as a cause for hemiplegic shoulder pain, it's a very broad list. And there are different reasons for this. One is it's likely that there are more than one mechanisms that the shoulder pain is caused by after a stroke. And also the admission that we don't know all there is to know about hemiplegic shoulder pain. So there have been different ways of systematizing etiologies for shoulder pain. This was from Kalikman, it was published in 2011. And many of the theories are that impaired motor control of different sorts, whether it's a flaccid motor control or spastic motor control, increase the risk for soft tissue lesions that then can create hemiplegic shoulder pain. There are also changes in the nervous system that can contribute to this as well. It's important to stop now and make sure we're getting on the same page of what hemiplegic shoulder pain is for the rest of this discussion. You know, as I said before, it's a very broad syndrome, but not all of that is relevant to the evidence regarding peripheral nerve stimulation. So particularly related to altered peripheral and central nervous system activity, there's a number of different aspects of shoulder pain that we won't consider. One is peripheral nerve entrapment. And really, this is more theoretical than something that is known to happen. This is based on the idea that if somebody has glenohumeral subluxation, that there can be either traction or entrapment of brachial plexus nerves to create shoulder pain. So that's not well documented that it actually occurs. Shoulder hand syndrome is also known as complex regional pain syndrome. So that can cause shoulder pain, but that's not something that's been studied with peripheral nerve stimulation as a treatment, nor has central post-stroke pain. And in fact, people with those diagnoses would have been excluded from trials. Spatial neglect would not be considered in this syndrome, and also adhesive capsulitis, which is clearly a different entity than what would have been included in any of the studies. So otherwise, the syndrome of hemiplegic shoulder pain that has been included in the trials is still very broad, includes many different pathologies. So there are a number of options that are available for treatment. When looking at randomized controlled trials for hemiplegic shoulder pain, it's clear that we don't know as much as we should. Considering oral analgesics and physical therapeutics or exercise-based therapy for shoulder pain after stroke, those are standards of care, but we don't know how well they work. And partly that's due to the many different things that are associated within those treatments. There are many different oral analgesics that could be used. Not one of them is preferred for hemiplegic shoulder pain, though we do avoid some, such as NSAIDs, which increase the risk of stroke. Physical therapeutics is also something that's very broad in its application. So different therapists use different techniques, different institutions, and the techniques are also tailored to the individual who's receiving treatment. But again, those are standard of care. All of my patients tend to use those in one form or the other. There's some evidence for botulinum toxin treatment in the treatment of spasticity for 1 month after a stroke, but not beyond that. There's some evidence for robotic therapy and corticosteroid injections being efficacious at 1 month. Corticosteroid injections have some evidence at 3 months. Suprascapular nerve block is shown to be efficacious out to 3 months, though interestingly, the 3-month data also include, as the injectate, corticosteroids. So it's not sure if it's really a nerve block effect or whether it's a systemic corticosteroid effect. So surface electrical stimulation in the form of neuromuscular electrical stimulation where muscle contraction is the goal is known at this point through multiple systematic reviews to not be effective. Though percutaneous peripheral nerve stimulation, where muscle contraction is the goal, has been found to be effective in multiple studies. It has been shown that after a temporary treatment, that there can be long-term effects 1 year after the cessation of treatment, that individuals are still doing better than control therapies. And we'll go over some of this. So percutaneous motor peripheral nerve stimulation for pain relief is based on the prior treatment of using surface stimulation to create muscle contraction to improve biomechanics at the shoulder. Decades ago, this was more common than it's used now, and it was thought that subluxation was one of the biggest contributors to having hemiplegic shoulder pain. So the idea was to stimulate the muscles to create muscle contraction that would improve the strength of the muscles, reduce subluxation, restore more normal biomechanics, and thus resolve shoulder pain. Much of that is not believed at this point, but that was the basis for why percutaneous peripheral nerve stimulation was invented. So this was invented by my chairperson, Dr. John Che. And the reason that the percutaneous form was designed was because patients who were undergoing surface stimulation found it difficult. They would wear these electrodes for many hours a day over the course of weeks to try to get the effect. And that was painful. The skin's a poor conductor of electricity. So to have a high enough intensity create muscle contraction can stimulate receptors within the skin to create pain. It's also difficult for patients to make sure that the electrodes are getting over motor endpoints to create strong enough muscle contraction as well. So having a percutaneous system in which electrodes were tunneled to the muscles provides a way to anchor the electrodes in the muscles for long-term use, also bypasses the painful effect of the skin. So the initial way this was designed was actually with 4 different leads going to one each to the trapezius of the affected shoulder, the supraspinatus, posterior deltoid, and middle deltoid. And for those of you who are involved in research, the case report for this treatment was first published in 2001. And it took until, I believe, 2018 for the treatment to be FDA approved. So it's a very long road to get new treatments out to our patients. So in the current use of peripheral nerve stimulation for hemiplegic shoulder pain, it's with a percutaneous electrode, with a single electrode that's placed through the skin, and it's anchored into the deltoid muscle in between the middle and posterior deltoids. And the anchoring reduces the risk for migration. That's attached to an external stimulator. And that stimulator provides an electrical current to stimulate the motor endpoints of the axillary nerve so that the middle and posterior deltoid muscles contract every 30 seconds. There's a 5-second ramp up. It says that it's maximum for 10 seconds, a 5-second ramp down, and then off for 10. And then so it repeats that 30-second cycle. Most of the research has the stimulation dose at 6 hours per day. And the FDA has approved this device for the use for 60 days, so that the electrode that is placed through the skin can be in place for 60 days. It can be used for a shorter duration as well. When the treatment has ended, the electrode is removed through gentle traction. That happens in the clinic. In between the implant and the explant of the electrode, the person using is in the community. They can really do what they want. They control when stimulation occurs. There's some ways to control intensity. So it's really a pretty easy treatment for participants once they have the electrode in place. This is a short video showing the implantation of the percutaneous electrode. So this is information that comes with the tray, or instruments in the tray. So the test electrode is placed through an anesthetized portion of the skin. The stimulation is used to test contraction of the muscles, which you can see by movement of the test needle. A sheath is left in place so that a wire electrode can be introduced to the location that was already tested within a needle introducer. That is then connected or tested, that has been cut out due to time. But the needle introducer and the sheath are then removed, leaving the wire electrode in place. That's hooked up to a connector and cabling so it can be connected to the stimulator. But the goal is for the person to have comfortable contractions that they can tolerate for up to 6 hours per day. The way you see the electrode exiting the skin and the connecting block is what a person would go home with. They cover this with Tegaderm. They're able to take a shower with a Tegaderm covering. We only ask that they not submerge their shoulder into water. So no baths, no swimming, but otherwise they can do what they want. The stimulator that you see on this person's back would be in a convenient location for when they're undergoing treatment. It's just that they're back here because of the sterile field and to allow the coordinator to have access to it during the implant procedure. So there are a couple of devices that have been tested in the treatment of hemiplegic shoulder pain. So this is the Sprint PNS system, it's manufactured by SPR Therapeutics in Cleveland, Ohio. This is the direct descendant of what was invented by John Che. So it's a minimally invasive procedure, as you've seen, for implantation. These stimulators can have 1 or 2 electrodes for stimulation. So as you can see in this picture, in the treatment of low back pain, where there are muscles that are bilateral, you can have 2 channels for stimulation. In case of shoulder pain, it's typically 1 channel. Again, the FDA said the electrodes can stay in place for up to 60 days. In practical use or in the clinic, the amount of stimulation is prescribed by the team who's implanted it. For motor stimulation, in which motor endpoints are stimulated to create muscle contraction, most studies for different applications have used it for 6 or 12 hours a day. There are some applications for sensory stimulation, so the stimulation of sensory nerves, in which it's used all day long. So particularly in the case of post-surgical pain relief, it's used for 24 hours a day. Again, for shoulder pain, it can be implanted and explanted in an ambulatory clinic. It doesn't have to be in a procedure room. And for shoulder pain applications, it doesn't require any external imaging. It's pretty simple to get the lead implanted within the deltoid muscle to stimulate the motor endpoints. Though some sensory applications do require imaging to make sure that you can get the electrode close enough to a nerve. The stim router is also an available device that's approved by the FDA that has been studied for the treatment of hemiplegic shoulder pain. So this is not percutaneous. There is an electrode that is placed completely under the skin. The energy for the stimulation as well as control is sent through a device that's worn on the outside of the body. It's to an adhesive pad stuck to the skin, and there is a remote control to control the external pulse transmitter. It's rechargeable with an external power supply. An implant isn't very invasive. That's minimally invasive, but explant of the electrode, if it needed to come out, is much more invasive. Are there any questions about implantation or the devices used for peripheral nerve stimulation before we go into discussing the evidence?
Hi, Rich. This is Preeti.
Hi, Preeti.
Great to see you here. Yeah, my question was, this is very exciting. Oops. So, sorry, ambulance all around me. But I wondered if, so is it wireless? Why is it that the BioNS device is more invasive than than the Sprint PCS device?
So in the case of the BioNS, this electrode is completely under the skin. None of it is traversing the skin. So it is intended to be a permanent implant. So once it's there, the hope is never to have to remove it. So the implantation is a little bit more invasive, but it's still considered minimally invasive. But the explantation, because the skin grows over it, there's no access to it. Once it's in place, becomes more invasive. In the case of the SBR system, there's a wire electrode that is introduced with a needle, but that electrode remains protruding from the skin throughout use. And at the end of use, at the end of whatever time period it's intended to use for up to 60 days, it can be removed just by gentle traction at the end of the electrode.
I see. So is there the potential for infection? Is the potential for infection greater with any one of these because the wire is sticking out?
The short duration of use for the Sprint device is one reason that it's not that big of a risk, but then also it's thought that the design of the electrode contributes to a low infection risk. It's a coiled design that allows the tissue to scar around it to prevent bacteria from going from the skin surface into the body. So in that way, it's a pretty low risk, even though it's a percutaneous system that has something going through the skin for 2 months. The BioNest has a pretty low risk for infection as well. There are other implanted stimulation devices that have a much higher risk.
Got it. And is it only, could it be done in any muscle, or is it only specific muscles that the implants are approved for?
It can be any muscle throughout the body that it can be used for. And again, some applications are muscle-based and some are sensory-based. So it may not be a muscle target, it could be a nerve target. In the case of shoulder pain, the Sprint device has only been studied stimulating the middle and posterior deltoids. The earliest method for stimulation that was invented by John Che, they actually used 4 electrodes stimulating trapezius, supraspinatus, a posterior deltoid, and middle deltoid. People might use it differently in the clinical realm, but it's not been studied that way.
Thank you so much.
You're welcome. So the first randomized controlled trials I'll go over were, they were conducted here at our institution. And the question was whether or not single lead peripheral nerve stimulation was better than physical therapy for chronic hemiplegic shoulder pain. So this is after the earlier randomized controlled trials utilizing the 4 lead system. So as a single site randomized controlled trial, we recruited those who had shoulder pain after stroke. They had to be adults. The pain had to be chronic, so at least 3 months of having shoulder pain after their stroke. It had to be moderate to severe, so it had to be at least a 4 on a 0 to 10 scale, 0 being no pain and 10 the worst pain. And that was based on the worst pain somebody experienced in the last week. They also had to have some sort of weakness of their shoulder abductor. So anything less than full strength would suffice. The participants were randomized to 2 different treatments. The first was peripheral nerve stimulation, as I've described. So it was a single electrode placed between the middle and posterior deltoids to stimulate the motor endpoints of the axillary nerve to create muscle contraction every 30 seconds. And that was done for 6 hours a day for 3 weeks. The electrode was in place for 4 weeks total. The first week was a period of not having stimulation to allow some scar tissue to form around the electrode. The alternative treatment was an exercise-based treatment that we term physical therapy. So this was 8 hours of physical therapy over 4 weeks. So 2 hours per week. The therapist educated the participants on proper positioning and handling of the hemiplegic limb. Slings were issued if it was felt to be an improvement. The therapy focused on improving range of motion and strength, as well as task-specific therapy to improve activities of daily living. Participants were also given a home exercise program that they were advised to use during the 4 weeks of therapy and also during the 3 months of follow-up. So 25 individuals were recruited to the trial, 13 randomized to peripheral nerve stimulation and 12 to physical therapy. Our primary outcome was the worst pain in the last week, 0 being no pain, 10 the worst possible. And this is showing a week of the trial. In terms of chronicity of shoulder pain, about 60% in each of these groups had shoulder pain for at least 18 months. So most of them, on average, were well into the chronic phase. So both groups started off in the severe pain range at about a 7.5. And you can see that with treatment, both groups had improvement. Though the peripheral nerve stimulation group experienced greater improvement. So we expect the physical therapy group as a control to also improve. They're receiving active treatment. At the end of 4 weeks, treatment ended, except for the advice of the group with physical therapy to continue their home exercise program. And then they were followed for a total of 3 months. And you can see that those in the peripheral nerve stimulation group maintained that reduction in pain to a greater extent than those that received the exercise-based therapy. So this is also something we see in our clinics, that patients do very well when they're working with therapists. And for some reason, after therapy ends, some of those gains tend to be lost. But at the end of treatment, there was a statistically significant and clinically relevant advantage to peripheral nerve stimulation. So we also had a measure for global success of pain relief. This was a reduction in pain of 30% at the end of treatment that was followed for the remaining follow-up time assessments over the 3 months. So 67% of those with peripheral nerve stimulation experienced success, compared to 25% in the control group. So at the end of this trial, we concluded that single lead 3-week peripheral nerve stimulation was more effective in reducing pain for at least 3 months than physical therapy. There were some other outcomes that were measured in which both treatments were effective in improving pain, but there was not a statistically significant difference. Both experienced a reduction in pain interference. That's from the brief pain inventory. It's likely that the clinical difference that was estimated, or the difference between peripheral nerve stimulation and physical therapy, was clinically relevant with a greater reduction for peripheral nerve stimulation. Both experienced improvement in bodily pain quality of life. That was measured by the SF-36. There's an improvement in both shoulder abduction strength and pain-free external rotation range of motion. It's unlikely that these improvements are clinically relevant for stroke survivors. There was improvement in upper extremity Fugl-Meyer assessment. And it was also found to be a safe treatment. So there were no serious adverse events with the trial. There were 3 individuals who had a portion of the electrode tip retained in their muscle. So in some individuals, there's more scar tissue around the tip, and during removal, a portion will be left behind. They don't feel it. It doesn't cause them discomfort. And we don't retrieve it. We give the person information so that if they were to have an MRI, since they're stroke survivors, that's something they might need, and lets the radiologist know how to obtain images safely with this metal being in the arm. So it has been tested up to 1.5 Tesla to be safe for MRI. So we were happy about the results of the first trial, but it was clear that things can still be changed to improve treatment. So we designed a 2-stage treatment for shoulder pain to try to improve from there. From our 2 prior randomized controlled trials, whether it's the 4-lead or the single lead, approximately 65% of those individuals receiving peripheral nerve stimulation had successful treatment, which was much better than the control situation. And while that seems to be much better, we wonder why it can't be 100%. So a study was conducted trying to determine which clinical factors in stroke survivors will predict successful treatment with peripheral nerve stimulation. And these were post-hoc data from the first randomized controlled trial of the 4-lead system. And in that, the peripheral nerve stimulation was delivered for 6 weeks. the number one clinical factor for predicting successful outcome was actually time from stroke, which is closely related to also the duration of shoulder pain for many of the stroke survivors. So you can see that with 6 weeks of 4-lead stimulation, that the peripheral nerve stimulation is associated with a robust reduction in pain for individuals who are closer to their stroke, less than 18 months. And the control situation, which is the use of a hemisling, there is a much lower likelihood of success. So 94% of these individuals had a successful response to the treatment, compared to 7% in the control group. If we look at those who are more than 18 months from their stroke, we see that peripheral nerve stimulation is associated with a reduction in pain. However, once treatment ends, their pain returns to closely mirror those in the control group. And in fact, there's not a difference between the groups. So we wonder what could be done for these individuals who still suffer from chronic shoulder pain that might improve their pain long-term. So we designed this 2-stage pilot study. This was 4 different sites throughout the United States as a convenient sample, single arm. So the stage 1 of this 2-stage treatment was the percutaneous peripheral nerve stimulation treatment that I've already described. We recruited participants who had shoulder pain for at least 6 months. So it had to be chronic, had to be moderate to severe, so at least a 4 on a 0 to 10 scale for the worst pain in the last week. They had to be refractory to 2 different treatments. That could be oral analgesics, a shoulder injection, or having gone through an exercise-based treatment for their shoulder pain. And they also had to have weakness of their shoulder abductors. So this first stage was 6 weeks in length, but it was divided into 2 different periods. So the first 3 weeks was a blinded sham introductory period. So the person had received the electrode, they were given the stimulator, advised on how to use it, advised to use it 6 hours a day, but the stimulator didn't deliver any electrical current. It appeared to deliver the electrical current. The battery would drain, but no current was delivered. And other studies about this method show that about 60% of people in the sham phase believe that they are receiving electrical stimulation. After 3 weeks, the participants were brought back. They were advised that we were changing their electrical stimulus so that it might feel different. So at that point, we put them in an active phase of treatment so that they would have electrical current creating muscle contraction every 30 seconds for 6 hours a day. So participants were considered a success if they had a 2-point reduction on a 0 to 10 scale at the end of the treatment phase compared to the end of sham, or if they ended the treatment phase as being completely pain-free. If they had successful treatment and their pain returned, they could go on to the second phase of treatment. So this was receiving an implantable stimulator that was placed under either general or local anesthesia. It was connected to an electrical lead that was anchored into the deltoid muscle, all completely under the skin. Participants would use the stimulation 6 hours a day and control it via a remote. The stimulator contained a battery that had to be charged every 2 weeks. Then we followed the participants for 2 years. So 28 individuals were enrolled in the trial phase. Of those, 5 had successful treatment of pain. Their pain had returned and they were eligible to go on to the fully implanted phase. On average, the time for stroke for this group was 3.1 years. So our primary outcome was, again, the worst pain in the last week. So 0 being no pain, 10 the worst pain possible. And this is showing week of the trial. So at the end of the sham period, so about midway through, there's a 36% reduction in pain. So we know that patients as well as research participants who are undergoing a treatment that's involved with a procedure are likely to have placebo effects, then these are no different. At the end of the trial phase, their pain had reduced to 71% of baseline. At that point, they received their fully implanted stimulator and they were followed. And you can see that throughout the follow-up time period that their pain was reduced by 80 to 90% of baseline. So this is a pretty big deal for this group, being more than 3 years from the stroke, who had chronic shoulder pain for a very long time. I'm often asked, well, how do we know if participants need sustained stimulation to control their pain? And based on this trial design, we don't actually know how long somebody needs stimulation to resolve their pain, but we do have a natural experiment from one of the participants. So this participant started off at a baseline pain of 9, underwent the trial phase that took them down to a 3. They then had implantation of the stimulator that completely resolved their pain with daily use by about 3 months. But then the stimulation was turned off. So this individual had a myocardial infarction. And when they were admitted to the hospital, the cardiologist didn't want the experimental stimulation being delivered, so asked for the stimulation to stop, which it did. And you can see that within 6 weeks, the pain had returned to baseline. At that point, the cardiologist allowed the stimulation to restart again in about 6 weeks, back down to a 0 out of 10, and they're maintained at a 0 or 1 for years. So I don't know if this is generalizable to other individuals, but it is interesting to have this one natural experiment. So there's a very good response, particularly looking at a 50% pain reduction for a successful outcome. When comparing to the end of sham, there was a more than 90% reduction in pain interference, and that's the brief pain inventory measure. And also improvement in pain-free external range of motion. Unfortunately, that stimulator was only available experimentally. It's not FDA approved, so it's not something that you could use for your patients. But the stim router from BioNest could be used. So it has been studied. There was a case series that was published by McRoberts. An abstract was presented at the North American Neuromodulation Society by McRoberts in 2016, in which 7 individuals with hemiplegic shoulder pain were enrolled in a trial. The stim router was placed to stimulate the axillary nerve, and then participants were followed. This wasn't a rigorous trial, so the follow-up period is from 1 month to 48 months. But you can see for this outcome of the visual analog scale for pain, 0 to 10, 0, no pain, 10, the worst pain imaginable, that looking at the green bars, which is the pain after stimulation, that all of these individuals that they graphed have a lower pain than their pain before stimulation. So this provides some evidence that this device could be used in a similar way that I showed in the other trial. So as Preeti mentioned, there are adverse events associated with peripheral nerve stimulation. So for percutaneous stimulation, the Sprint device, it's mostly skin irritation from having the device adhere to the return electrode that's in place for up to 2 months, or the skin covering over the device. There can be breakage of the electrode, which should be less than 10% when looking at all the available studies. There is risk for skin infection that's less than 1%. The fully implanted devices have additional risk. So implant site pain at 12%, higher risk for a pocket infection. That's for implant devices other than Bioness. There could be a lead fracture that would render the device useless at that point. And also reports in the literature of lead migration. This is the stim router migrating from the gluteus muscle. So when it comes to the mechanism, if this is effective, how does it work? We really don't know how it works, but we have some ideas. This has caused us to really look at what we think is happening and evaluate it. And as I said, we don't think the subluxation is the cause of shoulder pain, and the subluxation is not being addressed by peripheral nerve stimulation to improve pain. Not everybody with hemiplegic shoulder pain has subluxation. It's really only half of them. And we can improve people's pain without improving subluxation. We don't think that altered biomechanics is causing shoulder pain and being addressed by peripheral nerve stimulation. So we can measure improvements, but those are so small that they're not likely to be clinically relevant. Also, exercise-based therapies can also improve biomechanics, yet not be as effective in improving pain. And finally, we do not think that we're affecting spasticity. We've been able to show improvements in pain for those with hemiplegic shoulder pain, yet not affect their spasticity. So we are now thinking that whatever is happening pathophysiologically to allow chronic pain to exist is likely different than what caused the pain to occur initially. So there was something that occurred that caused acute pain, but then something within the body changes that allows it to be maintained for months or years after that injury. And it's likely maladaptive neuroplastic changes. This is a current thing for many different chronic pain syndromes. That is a problem within the brain or the spinal cord that's maintaining the pain. One of the things that is attributing to this, at least theoretically, is central hypersensitivity as what can exist to maintain a chronic pain state. So central hypersensitivity, for those of you who aren't aware, is an adaptive response of our bodies. It's part of our normal responses to pain or pending tissue injury. There are some parts of it that can be active peripherally, but then it can be completely mediated centrally as well. So this is a protective mechanism that our bodies use. It can result in spontaneous pain, or allodynia, having pain to something that shouldn't be painful. There's expansion of painful areas. When people with hemiplegic shoulder pain often have pain beyond their shoulder. It goes down their arm, it goes to their back, up to their neck. And there can also be diffuse hyperalgesia. So changes in the entire somatosensory system to change how pain is perceived or when it is perceived. So in experimental conditions, this lasts minutes to hours if the stimulus is removed. But it's clear that this can be maintained in the absence of a harmful stimulus in a pathological sense. And there is evidence this is happening in those with hemiplegic shoulder pain. So we conducted a study comparing those with hemiplegic shoulder pain to pain-free controls after stroke, and we evaluated their pressure pain thresholds. It's looking at what pressure that they start to experience pain. We do that with a pressure gauge as seen here. So at the affected shoulder, those with hemiplegic shoulder pain have an earlier onset of pain perception to the application of pressure compared to pain-free controls. That's not very exciting. Most of you would have guessed that anyway. But it's also the case at their non-affected shoulder and at the non-affected leg. So throughout the body of people with chronic hemiplegic shoulder pain, on average, they have a change in perception of pain. So this can only be mediated centrally. And it's well known to exist in other chronic pain syndromes that, compared to pain-free controls, those with chronic pain have a change in how they perceive pain. So if this is the case, how does it work? Now, this is our theory on what is happening. We haven't yet proven it. So peripheral nerve stimulation directly activates alpha motor neuron efferents, which is what creates muscle contraction, but also sends a signal through the afferents, the 1A's, 1B nerves. It's likely that the brain interprets the direct stimulation as noise, but the muscle contraction is different. So that is also sending information into the nervous system from the spindles, Golgi tendon organs, joint capsules, even cutaneous afferents, that the central nervous system understands. And we believe that this somehow interrupts that process that allows chronic pain to exist. And that in the case of peripheral nerve stimulation, you can actually get desensitization, that a temporary treatment can create long-term pain relief. It's clear that some individuals require persistent stimulation for pain relief, but many can have a temporary treatment for long-term pain relief. So in closing, what's coming next with this? And we wonder if we can actually have a better effect if peripheral nerve stimulation and an exercise-based therapy such as PT are combined. So we're at the end of a multi-site, double-blind, placebo-controlled randomized trial of those with shoulder pain after stroke. We're randomizing individuals to 3 groups, one looking at a combined treatment of peripheral nerve stimulation and physical therapy. And then we have 2 different groups that have a sham for either stimulation or therapy. So we're treating individuals for 4 weeks and then following them for a total of 6 months to look at long-term outcomes. The primary outcome is the worst pain in the last week, and we do have a global success measure. And then we have some secondary outcomes, many of the ones that we've also shown, but improving our ability to measure shoulder kinematics using optokinetics. Looking at quantitative sensory testing to evaluate changes in their somatosensory systems. And hopefully we can give you results in the next couple of years. So I'll end there, or I'll end with the summary of evidence. So there's level 1A evidence that peripheral nerve stimulation is associated with a reduction in chronic shoulder pain and hemiplegic shoulder pain. 1A, that it's associated with reduction in pain interference with activities of daily living. It's 1B, that's associated with reduction in shoulder impairment. Again, the clinical relevance isn't known. It's not likely clinically relevant. And there's 2B evidence that fully implanted peripheral nerve stimulation may be effective for treatment of hemiplegic shoulder pain in those who receive temporary relief from a percutaneous treatment. So I'll end there, and I'm happy to take any questions.
Quiet group today. Thank you for sharing. This is some really interesting use of technology. I think it's a nice addition to our tool set as opposed to just our typical medication route. So, Preeti, did you have a question?
Well, I just wanted to say thank you for a very stimulating presentation. Sorry, I had trouble switching my video back on. But I did have a question, but I didn't want to hog all the Q&A. So does anyone else have any questions?
I think you can go for it, Preeti.
Okay. Well, so I think it's very exciting and interesting to know that percutaneous muscle stimulation might interrupt this whole cycle of pain. How is this, what about TENS? TENS is based on a similar idea, but it's more just cutaneous stimulation. And the whole idea is this gate theory of pain. So is there anything in common with, is it that we are bombarding the central nervous system with this input so it basically overshadows the painful inputs and alters perception?
That's a great question. So different than TENS or spinal cord stimulation, which those are thought to work on gate theory mostly, though there are other theories on what might be happening. They're blocking the painful sensations from the periphery from getting to the central nervous system. That's the way they thought they work. They aren't associated with long-term pain relief. If you stop either of those forms of stimulation, the pain returns in a relatively short period of time. So what's different here is trying to communicate with the central nervous system in ways it understands, that using the body's receptors. So when the muscle contracts and you get changes in length and force, there are receptors that send information into the central nervous system that it understands. Spinal cord stimulation and TENS are not forms of stimulation that mean anything to the central nervous system. It just comes through as noise. So, and that is the main thing that we think is different and why this form of stimulation is more effective. It's, why is exercise-based therapy effective? It's likely moving the body. You get changes in muscles and joints, and that sends information into the nervous system. This might be similar. That's our theory and how we approach it. So until other forms of stimulation where you could provide sensory stimulation that the nervous system can interpret, it's unlikely that those will be more effective.
So in other words, you're stimulating the muscle, but you can stimulate it for longer than physical therapy can, because that's just episodic and for a short duration, whereas here you can go up to 6 hours, 8 hours.
Yes, and if somebody is not moving their limb, it's unlikely to be associated with a worsened pain to have a muscle contraction by itself, whereas going through an exercise-based therapy, the joint is moving and that may create pain. So then it may not be, that may be one aspect that's different for some individuals going through an exercise-based therapy, where here it's pain-free to get that information from the muscle going into the central nervous system.
Yeah. It's interesting that stimulating one muscle could have that effect. Yes,
there is, in non-human studies, there's some evidence that you can stimulate elsewhere in the body that it influence what's happening within the central nervous system diffusely. We haven't been able to study that in this case just because we can't get reviewers to agree to it to get us funding. But I agree it'd be interesting to try.
Great. Well, thank you so very much.
My pleasure.
Thank you again. I'm sure that if anyone has questions that come up at a later time, they can certainly reach out to Dr. Wilson and he may be able to help. And I appreciate everyone for logging in today and have a great one.
Have a good day.
Thank you.
Thanks. Thank you very much.